Hey everyone, I'm going to talk about the management of the shock. So we have hemorrhagic shock, septic, anaphylactic, and neurogenic, and cardiogenic and obstructive. Lastly, okay, so first of all, hemorrhagic shock, we're having some sort of loss of the blood. So we're gonna give IV fluid 1 liter for an adult, and the reason that we give IV fluid for those patients because they are losing some sort of fluid because it's hemorrhagic, they are losing blood, so we're gonna give them IV fluid as well as the blood, okay, in case of the in this case because they are losing blood, so that's why do we transfer blood to them. Um, the other thing is TXA. I forgot its name, but it is an acid that is called like a toxemic acid or something like this. And it helps to stop the bleeding. Maybe administer over 10 minutes, and then additional 1 gram should be administered over the following 8 hours. So makes sense. 10 minutes and then the following 8 hours. This is the TXA, as well as should be administered in less than 3 hours. Okay, so to recap, what we give in the hemorrhagic shock, basically we give fluid resuscitation, IV blood, and TXA. Okay, and yeah, that's all. This is in case of the hemorrhagic shock. What about once it is septic shock? Well, we're gonna give fluid and vasopressors such norepinephrine. All right. Um, Septic shock, like in any sort of shock, we're gonna have a loss of the perfusion or decrease in the perfusion that arrives to the organs. So why do we give the patient fluid? Because it's shock. The patient doesn't have fluid. The patient is run out from the fluid. So that's why what we do give him a fluid resuscitation. As well as the vasopressor, such as norepinephrine if still hypotensive, because the patient is experiencing infection and the patient has some sort of inflammatory response, so that would make the blood vessel to be dilated, and that why do we give vasopressor to constrict those vessels and to increase the blood pressure. And for this, we give vasopressor in the septic shock. We're gonna measure the lactate because of the anaerobic respiration that are produced by the bacteria and the lack of the oxygen, and we give antibiotic after blood culture. As well, like we're gonna take blood culture to know the specific antibiotic. Infectious source control, such as abscess drainage, line removal, Foley catheter removal, surgical exploration. So basically, after giving the patient fluid and vasopressor and antibiotic, right now we're gonna deal with the infection. We're gonna do the infectious source control, such as abscess drainage, which means that we're gonna deal with the infection after managing all of these things. So this is the septic shock. What about the anaphylactic shock? by first of all stop the offending agent, whether it's etc. like penicillin or peanut or any kind of source strawberry, whatever the source of the allergy, we're gonna remove it and we're gonna stop it. Intubation if needed, if there's laryngeal edema, and epinephrine is given because in this case, just the same as the septic shock, there's gonna be vasodilation of the vessels and low blood pressure. So that's why do we give vasopressor fluid resuscitation? Because it's sort of shock. The vessels are so wide, and we wanted to constrict those vessels because basically we wanted to constrict them and to increase the blood pressure. So fluid resuscitation, epinephrine, intubation, and stop the offending agent. Okay, the adjunctive treatments. For bronchospasm, we do give beta sympathomimetic and glucocorticoids as for second line. So, why do we give beta sympathomimetic? Because those sort of drugs are helping the patients to dilate their bronchospasm, to dilate the bronchi, that help them to breathe effectively. So that's why do we give beta sympathomimetic or beta 2 agonists for those bronchospasm patients. And we can give the patient antihistamines to suppress the histaminergic effects. So, in antihistamine and beta sympathomimetic or glucocorticoid could be given for the patient as an adjunctive treatment. Okay, so that's for the anaphylactic shock. Stop the offending agent, intubation, epinephrine fluid, and adjunctive treatments such as beta sympathomimetic, glucocorticoids, and antihistamine. Okay, with that being said, right now we're gonna take the neurogenic shock. What do we mean by neurogenic shock? So it could be from a trauma, from any sort of injury for the spinal cord. So in this case, we're gonna lose the sympathetic tone on the body. So the body is out of control of the sympathetic, and the parasympathetic takes over, and we're gonna experience some sort of things such as hypotension and vasodilation and just such parameters. So the first line treatment for hypotension is intravenous fluid resuscitation, and the reason because we wanted to increase the blood pressure because of the vasodilation that is going on the vessels. The vasopressors such as phenylephrine and norepinephrine and epinephrine, all of these could be given to increase the tone of the vessels, to constrict the vessels of the neurogenic shock. Atropine considered as well to treat the bradycardia, because those patients are having bradycardia because of the losing the sympathetic tone over the heart. So that's why do we give atropine for those patients? So consider atropine or cardiac pacing to treat the bradycardia. High dose of steroids to help decrease inflammation surrounding the spinal cord. So as I told you, the first place the spinal cord is going to be injured from certain trauma or certain injury, so we'll give the patient steroids to help decrease the inflammation. Treatment of the cause are just spinal cord decompression. Alright, by just doing some sort of like whether if it's trauma or some sort of heavy thing upon the spinal cord that makes the injury, we're gonna remove it, we're gonna decompress the spinal cord wherever the reason is. So treatment of the cause are just spinal cord decompression, steroids, atropine, epinephrine, norepinephrine, and phenylephrine, the fluid. All of these could be given to the neurogenic shock patients. Um, Cardiogenic shock, management of the acute heart failure, and provide supportive care. So basically, those patients are having some sort of problem in their heart, and we want to treat the underlying cause of their problem by treating the underlying cause and following the ACLS protocol and cardioversion, which means we give the patient electrical just electrical resuscitation, or we're gonna like to activate the heart contraction. So this is what we mean by cardioversion. And physicalization in case of the MI, because the vessels are impaired in MI, so that's why do we do rephysicalization. So we treat the underlying cause and the protocol and cardioversion and rephysicalization according to the cause. Just we treat the cause, and then like all of the things going to be done in perfect thing. Okay, so this is the cardiogenic shock, but be sure that this is the only shock that we don't give fluid because of the patient may develop pulmonary edema, because the patient already have overload of the fluid, so we don't want to give him overload of the fluid, so that will worsen the case. We're trying to be far away from those fluid and not giving the patient the fluid to not increase the fluid on the heart and the lungs. So this is an important note that we have to remember. Obstructive shock, fluid resuscitation, because these patients are having some sort of obstruction, let's say on the lungs or something, and we do give fluid resuscitation, and we do just treatment of the cause and decompression, just on the lungs, and then pericardiocentesis as well as done, and thrombolytics sometimes, because those patients are having some sort of clots, so we're trying to remove them up from just the blood. So sometimes being done the thrombolytic, and this because we want to decompress the lungs or the the heart. So basically, the obstructive shock is similar to cardiogenic shock, but we're trying to remove the underlying cause and to treat the underlying cause. So this is what we do in the obstructive shock, and sometimes we treat the clots. Okay. With that being said, thank you very much, and maybe I'll do some sort of recap. The hemorrhagic shock, the patient needs fluid the most, so we give the patient fluid. For the septic shock, we do give vasopressor, and the anaphylactic shock as well, we do give vasopressor. The neurogenic shock, we do give vasopressor as well, and a fluid and decompression of the cause. And cardiogenic shock, we do give we do treat the underlying cause. In the obstructive, the same, we do treat the underlying cause, and we can give fluid resuscitation, unlike the cardiogenic shock. Thank you very much for the listening. Appreciate it. Bye.